1853年，世界上第一台内窥镜诞生以来，内窥镜经历了从硬管到软管，从纤维到电子的各个阶段。如今，有一种有别于传统 CCD 电子内窥镜的 CMOS 电子软镜开始出现，以其电子镜的清晰、纤维镜的价格和使用简单轻便，带给了临床医务人员一种全新的体验和感受。这款可视电子软镜主要应用于2、3级医院的重症医学科、呼吸内科、麻醉科、耳鼻喉科、泌尿外科等科室。产品主要由无线视频发射器、视频显示器、操作部、插入部组成。产品的最大亮点就是它所具备的无线视频传输功能，使得它在市面上同类产品中独树一帜。有了此功能，让医护人员操作更便捷、无期无判，大大提高了内窥镜操作的效率。视频显示器分为5.0寸规格的掌上全视角液晶屏 VS50 和更大的10.1寸宽视角液晶屏 VS100两种。其中产品的科技感不仅体现在它拥有95%NTSC 色彩还原度，让医护人员看到更真实的体内组织颜色，还具简单方便的操作专业仪器。其中10.1寸的显示器还配备了无极变角度支撑支架，实现桌面多角度的平稳摆放。既是支架，又是充电座，即使给无线视频发射器充电，平时又是无线发射器的收纳座。高品质视频的 HDMI 接口，可以将实时视频同步输出到外接的大屏幕上，方便教学和多人观摩。同时可配工作站，并连接医院信息系统，直接打印报告，大大提高了诊治效率。手柄的设计让产品更科学合理，手柄上增加的指模印、按键的布局，使得手感更好，握持更加舒适稳定，长时间握持也不容易累手。黑亮光滑的先端头可以更顺滑地进入人体，具有5级可调照明亮度，可以看得更深更细。可向上弯曲180度，向下弯曲130度，自如进入肺部各支气管。产品采用了无光纤设计，纤维镜的黑点不再重现，维修不再频繁，图像还更清晰，好用而不易坏，非常便利及兼容性好的吸引按钮、活检阀和清洗管路。目前的 LF 系列可视喉镜已有外径2.8毫米一直到5.8毫米，未来还会推出外径2.8毫米带有1.2毫米通道、最大3.2毫米通道的产品，满足医院各个科室的不同需求，将彻底代替纤维内窥镜，为医护人员提供更多更好用的可视电子软镜。
Thank you for watching the video. Good morning, everyone. Good morning, Dr. Vasileios Kalyvas. It's nice to see you again. Okay, since this webinar broadcasts online at the same time, also we have hundreds of audience from China, Europe, Ukraine, from Africa, such as Nigeria, South Africa, Middle East, such as Iran, Egypt, also audience from Greece. So welcome all the audience to join us today. Please allow me to introduce myself, your host for today. My name is Sophia, and I am International Product Manager of Vision Medical. Vision Medical specializes in the development, innovation, and manufacturing of flexible video endoscope and provides the society with visualized medical equipment that can elevate the pain of patients. At the meantime, with the progress of modern medicine, there is differences between countries and regions. In technology, we hope to play a part of the effort so that our doctors, professors can conduct academic exchange. As with our vision, we make every endoscope affordable and benefit the society. So today, we are happy to announce this special webinar. We invite urology specialists from Greece to share with us the application and clinical experience of flexible cystoscopy in office. We're going to have two topics that we're going to talk about today. The advantage of portable flexible cystoscopy in clinical diagnosis and actual case sharing, which is presented by Dr. Vasileios Kalyvas. He is with huge experience, and he is consultant of urology in 424 Military Hospital, Thessaloniki, Greece. Fellow of European Board of Urology. PhD candidate in medical school. He's member of Hellenic Urology Association, European Association of Urology, and International Urology. He has been researched cases of follow-up for bladder cancer, urethral, man and female slut. And now he's going to introduce us the examination made by cystoscopy. At the end of the sharing, we set up a Q&A session. Once again, welcome all the audience to Portable Flexible Cystoscopy in Office. Now we are going to start the program. So welcome, Dr. Vasileios Kalyvas.
Hello, Sofia. Good morning from Greece. I would like to thank Vision Medical for this opportunity to give me to share my experience in portable flexible cystoscopy in office. And we will start the presentation. So, portable flexible cystoscopy in office. First of all, I would like to start with the definition of flexible cystoscopy, which is the procedure performed under local anesthetic that allows to look at the interior lining of the bladder and the urethra using a thin flexible tube with a tiny camera attached. Flexible cystoscopes combine both the optical system and the working irrigation channel into a single unit. There are two types of flexible cystoscopes, fiber optic and digital ones. As for the fiber optic, the optical system is composed of a bundle of optical fibers that are responsible for the transmission of images and two similar fascicles responsible for transmitting light. On the other hand, the digital cystoscopes based on chip-on-the-tip technology, which is placement of an imaging sensor on the distal tip of the cystoscope. So we have high-definition digital cystoscopes and standard definition digital cystoscopes. The technology of flexible cystoscopes. As I told you before, an imaging chip is located at the distal end of the cystoscope. This chip converts light energy into electrical energy and can be displayed on a viewing monitor. There is no eyepiece for digital endoscopes. Images are sent to the image processor, and high-definition optical resolution, color, contrast have been the major driving points to further this technological advance. These are the technical features of flexible cystoscopes. The bending, the tip bending, range from upwards 210 degrees to 220 degrees, and downwards from 130 degrees for some cystoscopes to 210 degrees. The field of view is approximately 120 degrees. The depth of view field is range from 3 millimeters to 200 millimeters. As for the outer diameter of insertion tube, range from 16 to 16.5 French. The inner diameter of instrument channel range from 6.6 to 7 French, and the working length is approximately 40 centimeters. There are several comparative studies for the advantages of flexible cystoscopes. As you can see in the pictures, there are 3 pictures of fiber optic, a standard definition, and a high definition cystoscope, the Vision CF52. The new high definition digital cystoscopes provided significantly improved visualization in a clear and a body field, resolution, color representation, and depth of field compared to standard definition and fiber optic. In the office setting, with proper care, both flexi and digital, both fiber optic and digital cystoscopes are durable for office application. Overall, surgeons significantly preferred the digital ones, as demonstrated by discrepancies in both use and differences in the subjective metrics. Also, flexible cystoscopy is a valuable procedure for evaluating the posterior urethra and bladder neck in cases of pelvic fractures, and complements the results of voiding chysteurethropy before surgery. Flexible cystoscopy combined with retrograde urethropy or voiding chysteurethropy may provide more accurate and more immediate information of diagnosis and surveillance in patients, improving the urologist's ability to select definitive therapy for a patient. So, if we have to choose between a rigid and a flexi one, which are the advantages and disadvantages? I can tell you that the disadvantages of a rigid endoscope are advantages for the flexible one. So, the main advantages of a flexible endoscope are more patient position options, smaller calibers, we have the ability to move, deflect, we can perform under local anesthesia, and we permit the patient to look the procedure, to be a witness of the procedure. We have less chance of overnight stay. They're painless, which is the main advantage, and there are less post-operation symptoms. Why should we do a flexible cystoscopy in office? The reason are, first of all, the diagnosis of hematuria, visible or non-visible, signs of lower urinary tract symptoms, urinary incontinence, bladder cancer, suspected bladder cancer, or a follow-up after transurethral bladder resection, the evaluation of bladder stones, signs and symptoms of an enlarged prostate, injuries of lower urinary tract, symptoms of interstitial cystitis, and the removal of a double J stent. Another topic that is very, we have to clear in our mind is what about the anticoagulator therapy before a flexible cystoscopy? First of all, a flexi is a low-risk procedure according to bleeding risk tables. Traditional oral anticoagulants therapy and antiplatelets can be continued if INR is within range. As for the novel oral anticoagulant drugs, the last dose of them should be taken 48 hours before the procedure in patients with normal kidney function. And now, what about flexible cystoscopy and periprocedural antibiotic prophylaxis? Flexicystoscopy is a short, common outpatient, as we told before, urologic procedure associated with a potential risk of post-procedural urinary tract infection. The risk of UTI described in the literature is up to 10%, and the recommendations for pre-flexible cystoscopy antimicrobial prophylaxis remain unclear. In a single-center retrospective study of patients undergoing outpatient flexible cystoscopy, the rate of UTI was 2.2% in patients who did not receive antimicrobial prophylaxis, compared to a rate of 2.5% in patients who received one. The EU strongly recommends not to use antibiotic prophylaxis to reduce the rate of symptomatic urinary infection when we do a flexing. And now we can start with the clinical cases. First of all, the clinical case number 1. It's about a male, 68 years old, with a medical history of right nephroureterectomy in 2019 with a PT1 low grade. After that, he underwent a TUR bladder resection on May 2020 with PT1 high grade plus BCG installations, 6 weekly installations. Also, he has hypertension and dyslipidemia under mitigation. He is a previous smoker, approximately 25 cigarettes per day, and he stopped smoking in 2019. He does not receive any antiplatelet medication. So we performed a flexible cystoscopy in office 20 days after the last BCG installation. This is the video cystoscopy performed by Vision CF52. First of all, we evaluate the whole urethra. You can see the flexibility. And now, this is the first finding. It's an urethral tumor. We endoscope very easily and quick the whole finding. We can see all the details, both of the urethra and of the tumor. And we can easily pass the tumor and continue the endoscope. You can see the high resolution of the chip and the tip technology. Now we're inside the bladder. We examine the whole bladder wall and we find a tumor in the area of the right orifice. There are another tumor in the anterior bladder wall. You can see all the details inside the bladder. We can examine very quick and very easy the whole bladder wall and the bladder triangle. During this cystoscopy, I took photos, both of the triangle and the tumors. You can see the flexibility of the cystoscope. We can bend the tip upwards and downwards to 210 degrees. I will move this video on. To show you another tumor just in front of the bladder neck. So we found very quick and very easy the urethral tumors, the bladder tumors, and the tumor in front of the bladder neck. And this is another image of the bladder neck tumor. And the whole procedure lasts less than 5 minutes. So these are photos shot by Vision CF52. The urethral tumor and the bladder tumor in the right orifice area. Now, the second clinical case, it's about a male, 54 years old, with a medical history of TURP on 1st of 2021, and 2 months after TURP, he had low urinary tract symptoms, and especially low urinary steam and prolonged urinary time. From medical history, he has hypothyroidism under medication. He's not smoking. He has regular alcohol consumption, and he does not receive any antiplatelet medication. This is the urofluometry 2 months, 3 approximately months after TURP. You can see the voided volume was 210 ml, Qmax 8.6 ml per second, flow time 38.3 seconds, and time to Qmax 2.9 seconds. You can also see the plateau curve. And I want to mention that the post-void residual was 75 ml. So we decided to perform a flexible cystoscopy in office. And this cystoscopy performed by Vision CF52. First of all, you can see the stricture in the penile urethra, just few centimeters lower than the external urethral orifice. We can endoscope very, very easily this stricture. We passed it quick and easily. We still endoscope the urethra. You can see the flexibility and the bending of the tip. I can easily pass any damages in the urethra. Now, you could see the second stricture. This is a second stricture just before the prostatic urethra. With gentle movement, we can easily pass this stricture. Just see the video. This is the stricture. Gently, we pass the endoscope and we still look the urethra. And now we're inside the bladder. We endoscope the whole bladder wall. There were no findings in the bladder wall. The orifices were undivided. I will move this video on. As I told you, there were no findings inside the bladder, but this is the bladder neck. I remind you, this patient was underwent under TURP 1st of 2021. This is very narrow bladder neck. We can easily pass it with the flexi. We took images during the procedure. You can see that it's very tight. It's a very narrow bladder neck. I will move this video. So there were findings of two strictures in the urethra, which easily passed with the flexi, and a very narrow bladder neck. The whole procedure, less than 8 minutes. So let's go to clinical case number 3. A female, 45 years old, with a medical history of recurrent urinary tract infections the last 4 years. She received antibiotic therapy in acute condition plus cranberry products, and she had 1 episode of visible hematuria. From his medical history, she has hypothyroidism, under medication, she is a smoker, 10 cigarettes per day, she has regular alcohol consumption, she does not receive any antiplatelet medication. So we performed a flexible cystoscopy in office. And this is the procedure. And this procedure performed by Vision CF52. We're inside the bladder wall. We endoscope the whole bladder wall. You can see that I can very easy bend the tip of the endoscope. Upwards and downwards very, very easily. And you can see, I will move this video. This is the left orifice. We're in the bladder triangle. You can see in a couple of seconds several white exophytic formation in the bladder triangle. This one is just in front of the right orifice. I will go narrow, so in a few seconds you will see better. We took also images, not only video, with the flexi. So we endoscoped the whole triangle, and we saw that this formation was all over the bladder triangle. I repeat that this woman had a recurrent urinary tract infection the last 4 years. You can see the other formation right here. So we have to go to a right position to a video and a photo with good quality. There were no other findings from the rest of bladder wall, such as papillomas. We evaluate again the whole bladder. I will move this video. And the whole procedure was less than 7 minutes. So after that, we decided to perform a contrast-enhanced computed tomography which showed that there was thickened bladder walls with normal upper urinary tracts. After that, she underwent two biopsies of the bladder triangle, which showed leukoplakia, keratinizing squamous metaplasia of bladder. There were no signs of malignancy, although. You can see in the right picture the normal bladder wall with bladder mucosa, urothelium, lamina propria, muscularis propria, and blood vessels and nerve bundles and connective tissue. On the other picture, you can see keratinizing squamous metaplasia with the keratin layer in front of it. The follow-up of this woman was annual cystoscopic monitoring to look for any malignant changes. So why should I choose a flexible cystoscope for my office? For many reasons. Some of them, low weight, as I told to other colleagues, is as light as a mobile phone. Its portability, you can easily transfer it everywhere. High definition resolution with a high definition distal tip. The capability to examine quick and efficiently lower urinary tract. And it's a painless method of endoscopy. I would like to thank you very much for sharing my experience with you. Thank you for your attention. And I would also thank again Vision Medical for this opportunity to share my experience.
Thank you, Dr. Vasily. Thank you for your excellent lecture and sharing. I believe we have learned so much from your speech. And also there's some question from the audience. And here's a question from audience. He asked, I was wondering if the image is clear when the cystoscopy enters the blender.
Yes, as for the image is very clear due to the chip-on-the-tip technology. Of course, a high-definition digital cystoscope is superior to a standard definition one. So images depend on the resolution of an imaging sensor. The high definition has very, very good quality of image.
Thank you. And the next question is, how many cases have you been done by flexi cystoscopy in a year?
Personally, I have made over 150 flexes in my office the last year. And I believe with a proper care and careful maintenance, you can achieve a very large number of cystoscopies.
Okay, here is the third question. I think it's from a doctor. He asked, I have some experience of this kind of portable cystoscopy, but the light source is not so powerful. And how is the Vision Medical which you was using?
As for the brightness, I think.
Yes.
Okay. In this endoscope of Vision Medical CF52, there are 5 scales of light. I usually use the 3rd scale. It is as bright as I want, and I can easily complete the cystoscopy without any problems and without any damages. So, in my experience and in my office, I prefer the 3rd one, the 3rd scale of light.
Mm-hmm. Thank you. And the next question is, cystoscopy can easily cause bleeding after surgery. So according to your experience, is it possible to have some technique to reduce damage to the patient urethra?
This is about the learning curve of a flexible cystoscopy. The learning curve of a flexi cystoscopy is higher than the learning curve of a rigid one. So if someone have completed a significant number of rigid cystoscopies and he participates in several flexible cystoscopy courses, he can easily achieve skills to reduce any possible damages. So you have to attend some flexi courses just to be sure that you will not damage your patient.
And practice, right?
And practice, yes, of course.
Okay, here's another question from us, from Vision Medical. Is it the specification of cystoscopy is enough for clinical needs? We want to get some suggestion from your side, from doctor's side, to improve our product. Like, for example, maybe smaller outer diameter.
I think that we all agree that the smaller the endoscope, the happier the patient. Okay, we need a thin tube inside his urethra. But this type of endoscope is sufficient for clinical cases. As a suggestion, I could say that in the future we have to focus in a smaller outer diameter, so to minimize any possible damages in the urethra. But I believe that this type of endoscope is very sufficient for any urologist in his office to perform flexes without any damages.
Okay, thank you. I got my answer. So, is there any question from the audience? If we have no further question, then we will conclude the session. And we would like to thank Dr. Vasileios Kalyvas. Thank you, all the audience from all around the world. And thank you again for the great lecture. And thank you for being with us. And we hope to see you soon. And I hope we can see each other face to face. I know Greece is a very beautiful country. I hope I can be there when this cholera crisis will subside.
Yes,
thank you so much. Yeah,
thank you very much.
And welcome to China.
Thank you very much for the invitation. And I would, in the future, we have to discuss another topic of something else.
Yeah, maybe we have another topic. We can have conversation with other doctors from other country.
Yes, I think the better is to say all of us the experience that we have in our office in different countries, in different cities, so we will be better for our patients.
Yes. Thank you so much, and thank you all the others for watching. Okay, bye.